We're delighted to have Dr. Teresa Chapa join us to give this webinar today. Teresa Chapa, PhD, MPA, serves as Executive Dean at the California School of Professional Psychology at Alliant International University, where she provides leadership and oversees 6 accredited schools of psychology and 3 international campuses. She has had a distinguished career in public service, most recently in the U.S. Department of Health and Human Services, Office of Minority Health, or OMH, Office of the Secretary, where she established and led the Behavioral Health Section and integrated behavioral health care in her position as Senior Policy Advisor for Mental Health. She had previously served as OMH Director of the Division of Data and Policy, Chief of the Office of Extramural Research for the National Center for Minority Health and Health Disparities of NIH, and Special Expert to the Substance Abuse and Mental Health Services Administration. She was awarded a 2-year intergovernmental employee assignment to the National Hispanic Medical Association, where she served as Executive Director and promoted integrated behavioral health care strategies to provider communities. Dr. Chapa is the recipient of numerous awards, including the A. Bush Leadership Fellowship and the American Public Health Association Helen Rodriguez Trias Social Justice Award for her work in mental health disparities for underserved and disadvantaged populations, and has published several papers and policy briefs focusing on building a behavioral health care workforce and promoting quality care. Earlier in her career, she received specialized training in infants, children, and families, and served as a clinician, supervisor, and mentor in California and Minnesota, working at university, county, state, and community-based settings. Dr. Chapa received her PhD in clinical psychology from CSPP, Berkeley, and a master's in public administration from Harvard Kennedy School of Government. And now I'd like to turn it over to Dr. Chapa for the webinar this morning.
Good morning, and thank you so much for that wonderful introduction. I also want to thank Dr. N for this invitation to speak to you and look forward to being able to share some of what a little bit about cultural competence and integrated care settings and across the board, and to listen to your questions. So let's get started. I think you've had a chance to look at the presentation goals. I changed them just slightly from what was sent originally so that we could look at some numbers first. And then we'll look at items 2 through 6 as seen here on the screen. I don't want to spend a lot of time on this because you have that in front of you. And I think one of the most important things that we start with always is looking at who we are and who's out in the country, who are we serving. If you look at these numbers really as ethnic minority populations, racial and ethnic minority populations, we're really almost 40%, and this could even be an undercount. And keep in mind that in some states we are majority minority, so we want to be able to look at services, deep dive into them, look at our communities, but also look at our population overall, because policies and strategies are built based on that, and monies are allocated based on that. And one other thing I think that's super important for us to keep in mind is that most people don't get mental health services. And so this particular slide gives an overview on why. Most people say that it's because they can't afford it or insurance won't cover it. But I think that we know that there are so many other reasons why people don't get the care they need. We also want to say that fewer adults seek a mental health professional. We know that children get mental health services in different ways because they're usually referred to services through their schools or pediatricians, but adults here who experience serious psychological distress typically do not get service. And you see on the right-hand side the numbers are low as well. And here we have a slide on utilization that really pinpoints Asians and Hispanics. And I think that what they're not really highlighting here, I mean, it has all of our groups, but what they're not really talking about here is probably services in other languages. But if you look at these numbers carefully, we're not getting the services that we need typically through accessing a mental health service clinic. And our communities do say that cost is important and that it's a tremendous barrier, but let's look at some of the other issues as well. Oftentimes our communities feel that they don't need services, that they experience prejudice and discrimination. They can't get the services they need because they're not easy to access or through transportation problems, or some folks may live in rural areas. Even in urban areas, they may not have access because a bus is not available to take them there. But also there's people who just think they don't need services. And I really think that one of the main issues in all of this is stigma. And so we need to know and remember that mental illness is one of the leading causes of disability, and that 2/3 of our populations with diagnosable mental illnesses just don't get the services they need. And if we look at racial and ethnic minority communities, they're less likely to get those services. So we really need to look at other ways, not just talking to our friends and families, but that's also important, health promotion, health education, but also looking at mechanisms to provide services in ways that are less stigmatizing. So here we have some of the common reasons for delaying care. Lack of understanding, and this is common for our racial and ethnic minority communities, and particularly those who do not speak English or maybe recent immigrants who don't fully understand what mental health services are. And so if you don't know what they are, you certainly wouldn't know how to access those services. But if you look at some of these items, some of our individuals don't have insurance, which is why our community clinics are so important. They suffer tremendous issues of stigma and shame and fear of being labeled in their community. They think that this is a personal weakness. And the cultural differences in approaching treatment are significant. Many members from our racial and ethnic minority communities, they're used to speaking to friends, to neighbors, to priests, pastors, and curanderos. And I don't know if you know what a curandero is, but it would be a healer. So we do have in a lot of our communities native healers. And then there's just an overall distrust of the provider community, and that would be more the mental health provider community. What are they going to do to me? They're going to give me pills. I don't want pills. They think I'm crazy. They might lock me up. And for some persons who are from other countries, they meant going to jail. So these are pretty significant barriers. Other barriers that are more systemic barriers is that oftentimes our communities don't have usual sources of care. Again, locations could be hard to reach or out of the way, and sometimes because of not understanding the language or understanding the culture or understanding the cultural presentation for you, there's problems potentially with the accuracy of the diagnoses. Poor timing is significant, and I know for all of you in the integrated care movement and settings, you know that how important it is to have that warm handoff. I even call it a hot handoff when it comes to our communities, because if they're out the door, they're not coming back, and we've got to work hard on making sure they get seen immediately. And of course, you know, just a history of missing care coordination, which still exists in most places, and few providers with cultural and linguistic competency. And this is super important because if you look at who we are in the community as providers, if you look at our minority communities, fewer persons are graduating with college degrees that would allow them to go into higher education. So there's a lot of work that needs to be done there as well. We can't forget that. And then because of not really having this coordinated care and not looking at maybe health care in mental health organizations and vice versa, there is documentation that there is increased morbidity and mortality, and largely due to treatable conditions. And I have here cigarettes and junk food, and it says 60% of premature deaths in persons with serious mental illness are due to natural, I have quotation, natural causes. But, the data for this study, which was good, really didn't talk about racial and ethnic minority communities. So I would venture to say that for those communities, those numbers could be a lot higher. So, but from the study, at least, we've come up with these three messages, and that is overall health is essential to mental health, recovery includes wellness, and recovery is possible. Another element which is extremely important for us in the way that we approach our clients or patients is to really fully understand social determinants of health and their impacts on disease, prevention, communication, access to care, and just the ability to meet you in joining you in a clinical setting, in a clinical rapport, and following through. And let me give you some of the determinants that I think are key. From the patient perspective and the social perspective, racism and discrimination, low income, unemployment, poverty, homelessness, addictions, trauma is key, violence and crime in our neighborhoods and in our personal homes, children who are in out-of-home placements, foster care, the list goes on. Incarceration, and we know right now in this country we're looking at incarceration, those individuals who've been in prison for years because of drug abuse or drug crimes, and also comorbid and chronic health conditions like obesity, diabetes, cardiovascular, stroke. I added other diseases that affect some of our minority communities in larger numbers. Hepatitis B, let me put hepatitis C, sickle cell, HIV. These health concerns and conditions have enormous impacts on behavioral and health outcomes. So with that in mind, and speaking to the work you do, we see, and through our research, that primary care settings have been, in many ways, a wonderful gateway to health care for racial and ethnic minority populations, and those individuals with limited English proficiency, we'll just say LEP from here on out, and as such is or can be the portal for identifying those undiagnosed and untreated behavioral health disorders. So if people are going in, for a checkup or because they're getting a flu shot or they're just getting a wellness exam, this is a great opportunity to be able to do some screening. So why integrated care for our populations, our minority and LEP? Because we've seen that it's improved access with less stigma. It's an opportunity for us to see the whole patient or client. In many places, it's a same-day service and same-day billing. And we can provide comprehensive care and do that warm, or as I say, hot handoff. If it's structured appropriately at the community level, it includes cultural and linguistic service provision, and it combines demonstrated knowledge and empathy of social determinants of health. So we look at our patients when they come in that door as whole beings, whole persons who have a set of issues and life experience that they bring on and into that door. And some of those factors affecting the quality of health care for our populations is that even though we're trying to do our best, primary care typically does not have the expertise in providing behavioral health services, and behavioral health clinics do not have the expertise in providing behavior in primary care. So this is an excellent opportunity to change that paradigm. We know that we have provider shortages and that we have network insufficiency. So when we're looking to build out our communities and to build up our clinics and services, we need to keep that in mind and think of strategies on how to improve shortages. We have an extreme lack of bilingual language capacity. So whether it's Creole or Spanish or Mandarin, whatever language, Russian in Northern California, we just don't have the capacity right now. That doesn't mean we should say we're not going to build it. Hey, that's where we're at. Let's just get interpreters. We do need interpreters, but we also need to build that capacity. And if you have interpreters, you have to use the right type of interpreter. Oftentimes our clinics pull our janitors, or they bring a child that interprets for their older family member. It causes a lot of problems with embarrassment and confidentiality, so there should be an interpreter training. And we really do have very few culturally competent services. We know that in our hearts we want to deliver this way. We know what we think should be the best way to deliver services, but they're just few and far in between. According to patient surveys, there's poor doctor and patient communication, and so oftentimes the doctor or the clinician or the mental health provider may not know quite exactly what might be going on, and this is an important area to beef up in order to have the correct treatment plan. And behavioral health conditions are really expensive to treat. So there's great opportunities in these challenges. Again, we want to look at the role of integrated healthcare in the Affordable Care Act. And in that Affordable Care Act, there was a promotion of integrated behavioral health and healthcare and a look at the patient-centered medical home. And these highlighted, all of these points were part of it. But for this webinar, we're looking at improved access to behavioral health care, addressing the social determinants, recruiting and training cultural and linguistic competent workforce, and create quality of care improvements and affordability of services. I just want you to know that even before the Affordable Care Act, that folks at the Fed were looking at these issues. In fact, 10 years before that, and were able to join into the dialogues in the communities and promote these issues so that it was a part of that dialogue. And right on your campus, you have a really good friend and colleague, Daniel Dawes, who just wrote this book, 150 Years of Obamacare, where he lays it out. He lays out what it took to get this job done, what it took to put the language in place, and what steps were implemented to have community input and minority voices in that law. So integrated care strategies can potentially eliminate behavioral health disparities. How is that? Because if we create our systems correctly, it's a portal to entry for all care. It can be culturally competent. You can have multiple language providers and really good interpreters. Those integrated care sites are really about promoting the best, promising, and evidence-based practices and make sure that they are culturally and linguistically appropriate. They support efforts to build that diverse, multidisciplinary team and leadership that's just so important in providing care that people want to come to and follow up with, and also improves health and behavioral health care by addressing the role of social determinants and, of course, learning collaboratives, best practices in disseminating strategies, efforts, and information by sharing experiences. So just a tremendous opportunity. So there was a lot of talk about cultural competence, and that could be a whole series and a whole semester combined with training on the ground. But in a nutshell, cultural competence is really about effectively being able to relate and work with individuals and be with individuals and live with individuals and be respectful of individuals and communities and countries from various groups and backgrounds. And we want to, in services, create those that respond to the unique needs of members of all our communities. We want to be sensitive to the way in which people with disabilities or any of our communities come in and experience our services and the world around them. And we want to be able to ensure that we have a guiding principle that is culturally sensitive and appropriate to provide prevention, outreach, assessment, and intervention. So it'll be absolutely important for us to really know and read about race and ethnicity and the impacts, the role of language, sexual orientation, gender, age, disability, socioeconomic status and class, educational attainment, religious and spiritual orientation, and more. But these I just put out as some very basic criteria. And people will say, Chapa, how did you get into this? Basically, from very early on, I read about history, I did ethnic studies, I read about slavery. I walked out of my own personal history and ethnic background to learn about others, and really had a desire and continue to have a desire to learn more and to develop more strategies and ways in which we can help our communities by being sensitive and knowledgeable, and then create strategies that work. So even though there are challenges in developing a cultural linguistic health and behavioral health care paradigm, like limited access to meaningful and quality care, all of the items that you see on the left that you know about, including overrepresentation of our populations in vulnerable populations, jails, etc. We really do have a challenge ahead of us, and that is building that workforce that's bilingual, bicultural, infusing cultural competence, learning about clinician bias and diagnoses and how to avoid those pitfalls, be those leaders where leadership is missing to promote and develop specific steps and mechanisms to create a presence, diversity, cultural competence in your clinic and in your work, and to blast stigma for our community, to normalize mental health services as a part of overall healthcare. So in looking at how to build a workforce, we spent quite a few years on this and working with folks across the country. We saw how difficult it was really to recruit, and there are mechanisms for this. Webinars are becoming very important. Getting to high school students, looking at our aging workforce and saying, okay, we don't want to lose our workforce regardless of age, but how do we bring folks up, mentor, actually having those conversations and guiding some of our younger or newer trained and graduated clinicians, and we want to look at the picture across the board and say, how can we fill those gaps? Some ways are really to learn how to attract and retain providers, especially those who are bilingual and bicultural or culturally competent. Oftentimes, in larger settings, people kind of take advantage of this workforce. If you know that this population group was 1% to 4% of the provider workforce, you might take a different look at them and say, how are we going to get these people, and be a little bit more competitive in our outreach and getting these experts into our clinical paradigms. We might also look at providing in-culture and in-language internships and supervision to give those who are bilingual that extra training, or those who are learning a language and right on the edge of being very good in that language, get you immersed in communities where you can begin using that language. And of course, build and support diverse and empowered leadership, because all the while we need those voices who help create policies and procedures that will help us work within this particular framework. So what are those organizational obstacles that we all need to overcome? Let's face it, changes are challenging. Change is hard. We all work across silos. Anybody who works in children's mental health or a pediatric clinic knows that there are multiple providers. It could be child welfare, it could be foster care, it could be a large family system, the education system. Across the board, we're dealing with a number of different agencies and providers and family members and advocates that need to be a part of a team, but we're working from a silo perspective. Build that multidisciplinary and cultural linguistic workforce. Really practice at that interprofessional training so that our mental health professionals learn how to work with health professionals and vice versa. Promote and evaluate new initiatives like this project, which is exemplary. Evaluate your work. We don't get enough of that evaluation. As I went around the country to look for best practices in delivering cultural and linguistic competent programs in FQHCs, I looked at those 5 or 6 models that actually wrote about it. They had numbers, they showed data, they had regressions, they showed that what they did actually had an impact and created wellness, but very few and far in between. So we really need to start documenting that work and elevating our scholarly articles in this arena. And also identifying new and ongoing sources of financing is always a challenge, but the times are changing and I think it will shift in our direction. Your mission, should you choose to accept this, is to go where our patients or clients are. Don't wait for them to come to you. I still see in schools of psychology and social work that we're training clinicians to work in a box. We're not training them enough to work in these types of settings. So it's absolutely essential that we shift that around to serving people to where they are. And today, we see more people in primary care settings. Embrace and adapt to healthcare reform. You see people resisting and fighting this and trying to fit existing care models. We want to create new models and to be able to fit into healthcare reform, because this is the new direction that will really have, and already showing, to have a larger impact, particularly on prevention and health promotion. Please infuse CLC into your services. Take that extra step. Walk that extra mile. Bring the right workforce together so that as a team you're really serving that diverse community that you say you're serving on paper. Evaluate and become more vigilant in tracking outcomes. Share, 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 and work more collaboratively. I think there's nothing better than learning best practices from colleagues and breaking that mold of, taking science to the community, which is 5 to 7 years. Just busting through that and start to share good evidence-based and practice-based information with one another. And demonstrate value and utility in the context of a collaborative care delivery structure. And I can't stop saying this, and I know that leadership is in your title, but provide leadership. That means stepping up to the plate. You have a good idea, make it happen. And so here it is. Who do you see and treat? On the left-hand side, we have this whole list of disorders that walk in the door, that people bring into the door with them. But how can you really understand those if you don't understand the cultural backgrounds of individuals and how they are sharing those disorders or displaying those disorders or verbally communicating their symptoms? And so we want to be very careful that culturally appropriate assessment, including addressing social determinants, is a part of everything else that's underneath there, which includes motivational interviewing, cognitive assessment, et cetera, et cetera, et cetera. It's just as important. And know why you do this. You do this because you believe in health promotion. You believe in wellness. You want health and wellness and cohesion and opportunities and access and health for our communities. Take the time to learn every day. Make a part of your agenda reducing stigma. Work with families and create the opportunity to educate and grow and be about social justice. That's cultural competence. You will always have challenges. That's okay. Each challenge brings an opportunity. And I know that when you're early in your career, it can be scary, but you have great ideas. Find or create a mechanism or a platform at your clinic to be able to share these ideas. Do a little bit of research. Promote, have an opportunity to have brown bag discussions and keep the education flowing and knowledge flowing for both your senior and your early career faculty and staff. And here is a paper that was written by colleagues and myself back in 2012. I have a list of papers and publications that I can share with you after this webinar. But this one was really bringing together experts from across the field to sit together and talk about what strategies and what ideal goals and objectives they would have to eliminate racial and ethnic disparities through the integrated healthcare model. So it includes all of these components: a lit review, the meeting, statements, recommendations, and innovations from the field. And I'm not going to spend a lot of time on the 3 paradigm shifts that were recommended from this, but I want them on the PowerPoint so that you can go back and review them. But really, it's about, one is about managing, creating administrative policies so that you can embed cultural competence. So that's really leadership, oversight, management, in how you're going to go about doing this and bring the right people to the team. And this one here underneath, it's about the organization strategy, and you can see where the two people say, well, I see 3 and I see 4. How do you bring people together so that they're looking at the same page? And third, clinical workflows. So are you monitoring what you do? What are you doing as far as quality improvements? And the way that we wrote this paper is to give you key examples of what this looks like in some of our minority and language embedded clinics. So a great resource for every one of you. And this is what one of the pages look like. I'm not going to go through all this with you. It's just to show you the flowcharts and the actual recommendations so that you can go back and look at this. And we did have 5 consensus statements. I think they're incredibly important. And it's really about creating integrated care teams that are culturally and linguistically competent, that they'll actively engage with patients, consumers, and families and communities across the lifespan, that those teams will recognize and and incorporate strengths of patients and their family members and their cultures, and that will permeate at all levels of assessment, diagnosis, and intervention, that these integrated care organizations will engage health and behavioral health, include health and behavioral health histories and really talk about those histories and get as much information from the patients themselves, and that you will become and remain a learning community, as we spoke earlier. I know there was a desire to ask, well, how did the national movement of integrated care and cultural linguistic competency actually come about? Now, I put the Affordable Care Act here on top, even though it really was not the first activity. The first activity came to the Office of Minority Health through the Office of the Secretary, a set of complaints from minority behavioral health directors across the country who were very concerned that they had no access to minority behavioral health leadership at the federal level. So that was about 2001, 2002, and they had asked at that point that our office put together a whole paper on what this might mean so we could look at strategies and next steps. What came out of that really was the development of a behavioral health section at the Office of Minority Health that had never existed, so very excited for that. But also, we had a primary and behavioral health care integration group. We have the Academy for Integrating Behavioral Health and Primary Care that came out of ARC, the Agency for Healthcare Research and Quality. We had the Centers for Medicaid and Medicare Services Healthcare Innovation Awards that began including integration and behavioral health. We also developed further the Office of Minority Health Integrated Care Initiatives, and of course the NIH National Institute, which was once a center on minority health and health disparities, now has behavioral health care leadership on site, which it did not have before. We have SAMHSA and HRSA that have grants and websites and tutorials as well. So the movement has really grown incredibly fast in a 10-year period, culminating to information that went into the Affordable Care Act and then out of it as far as recommendations for implementation. So a tidal wave of health reform has arrived, and you know that it's been very successful. There's still a lot to go. We still have some work to do, but we have met a tremendous objective of ensuring 20 million Americans that now receive coverage, which is absolutely phenomenal. There are funding changes underway. Some states or some communities do not allow same-day billing, which is a barrier for integrated care, but many more are opening up. Some states are revisiting carve-out for mental health so that we could remove it or change it or modify it so that, again, behavioral health services can be integral in the primary care setting. And bottom line, primary care has become the epicenter of healthcare reform. So it's a tremendous opportunity to look at that and say, how can we incorporate those values that are essential to our racial and ethnic minority and LEP communities? Make sure that those treatment centers, those doors, those portals are set up in ways that treat our communities in an effective and holistic way. And of course, that requires cultural competence. Also look at what's going around us in the world, because we're also included in the World Health Organization's Mental Health Action Plan, and a lot of what they're doing worldwide really refers to us and a lot of our underserved communities. And so again, when I looked at this, I go, my goodness, the objectives are very similar to our objectives for health equity, for eliminating health disparities, for promoting cultural and linguistic competence. And with that, I want to say thank you, gracias, merci beaucoup, and shukran.